Welcome to this week's episode of the Mustang Blueprint. I'm your co-host, Emeka. I have Amanda Sealing with me and our guest, Shannon Brewer from Avera. So, how you doing today?
I'm doing good, thanks.
Good. So, can you tell us a little bit about yourself?
Sure. So, I'm a clinical social worker, which essentially means a therapist. I got my undergraduate actually here in social work and sociology, and I had a minor in psychology, and then I got my master's degree from the University of St. Thomas and St. Catherine University up in the cities. I've been doing social work for over 30 years and currently work for Avera Marshall Regional Medical Center in both the inpatient unit and the outpatient clinic.
So tell us a little bit about what you do for Avera. What does that mean? Outpatient, inpatient?
Yeah, for sure. So we have an inpatient behavioral health unit at our hospital, which is a 10-bed unit on the third floor of the hospital. So there I provide group therapy and individual therapy, and then obviously work with a whole team of people. We have nurses, behavioral health technicians, our psychiatrist. And then in the outpatient clinic, I do individual therapy with ages 12 to like all the way to geriatrics. So I kind of run the gamut in the outpatient clinic.
Okay, and then obviously we want to focus kind of more on mental health. And I know Avera has certain services, but maybe people don't know about it. So what type of services does kind of Avera have for outpatients?
Yeah, absolutely. Good question. So in our outpatient clinic, we're a small outpatient clinic. So we have myself and I do individual therapy. We have Dr. Anne-Marie Vorbach. She's a psychologist, doctorate level. And then we have Michael Goblish is a psychiatric medication provider. Dr. Del Monte is a child and adolescent psychiatric provider. And then we have Bridget Albrecht. And she is an LGSW, so I actually supervise her, but she does therapy as well. So we're a pretty small team. And so mostly in the outpatient setting, we offer individual therapy and then psychiatric medication management for adults and children and adolescents.
So if I wanted to access the Avera outpatient services, how do I go about doing that?
Yeah. So you would just call our outpatient behavioral health clinic. That phone number is 507-337-2923. And you would follow the prompts there, which would lead you to our nurse. And she will start just a brief intake with you. And then we mail out an intake packet. And once that's completed and returned to us, then they give you a call back to get you scheduled for the first appointment. And we kind of use the information we get back to determine who's maybe the most appropriate provider and or who has the first availability.
So what would people expect from the first appointment? Maybe someone who's nervous, oh, I don't know what to, what can they kind of expect?
Yeah. So as far as the therapy world goes, our appointments are all of us across the board that provide therapy. Our first appointments are typically 45 to 55 minutes long. And that first appointment is really just about getting to know the person that we're working with, right? Talking with them about, what are your goals for therapy? What are your greatest challenges? What do you kind of want to work on here? And so it's really about just getting to know them at that point. And then from there, we determine how often people come back. So that also varies. That's very individualized. Some people are seen weekly. Some people are seen every 2 weeks. Some people are seen every 3 weeks, that kind of thing. So that's very, very much individualized. The psychiatric providers, they'll spend 60 to 90 minutes with you at your first appointment. So they spend a little bit longer period of time because they're reviewing maybe medications you've been on before, that kind of thing. But their appointments are similar. They get to kind of know you in that first appointment and kind of what do you need and that kind of thing.
And so just to be clear, can you talk a little bit about that difference between a psychiatric appointment and a counseling appointment?
Yeah. So as therapists, we cannot prescribe medications. So that's the biggest, huge difference, right? So if you come to me, I cannot give you medications. And so the psychiatric providers are able to prescribe medications and often do a little bit of therapy in their appointments too. It's just less than what we would do. Ours is all focused on that, and theirs incorporates a little bit of that, but they're going to be able to prescribe medications if that's what you're looking for.
Sure.
And then obviously we talk about mental health, but also before you kind of mentioned behavior. So we have behavioral health and mental health, but it's a little confusing.
Yeah, right.
So what's kind of the difference between them?
So, mental health just really kind of focuses on the psychological aspect, you are you kind of thing, where behavioral health would be more about what are the actionable things that we can do to change things. And it's interesting because they get interchanged a lot. right? Like those words get interchanged a lot. Like even the unit, if you come to the hospital, it's called the behavioral health unit, right? But really we're focusing probably on your mental health there, but we're also deploying, or our goal would be to give you some strategies and tools to maybe change behavior to get a different outcome too.
Well, okay, so let's talk about that inpatient side a little bit. You said you have a 10-bed unit on the third floor of the hospital.
Yep.
So how does somebody go about getting in, accessing the unit?
Yeah, for sure. So to come into the behavioral health unit, you actually have to go through the emergency department. So that's going to be your first stop. And reason being is that you have to be cleared medically before you can come into the inpatient behavioral health unit. And so that's part of our licensing criteria. We're considered a distinct part unit. So our beds don't count towards the hospital beds, it's goofy. But that's part of our criteria is you have to be medically cleared. So they'll run some labs. Right now we're testing for COVID still, just because we are a small unit. If we spread it around, we're shutting ourselves down essentially. So, so you'll come through there and they'll do a brief assessment with you. Part of that assessment in the emergency department might be doing a virtual assessment depending upon the situation with a provider out of Sioux Falls, especially after hours, because our on-call people are out of Sioux Falls after hours. So from 5 p.m. after. So you might encounter that. And then all that information gets gathered and delivered to our provider, and then we make a determination about whether or not we can meet your needs on our unit. You can come in voluntarily to the inpatient behavioral health unit, or if somebody believes you're at imminent danger and maybe you're not really wanting to stay, but they're concerned for you, the providers can put you on what's called a 72-hour hold, which essentially says you're coming up to the unit whether you want to or not.
Okay, that's interesting. So you talk about the 72-hour hold, like, all right, pretend maybe I know somebody and, I think, all right, maybe it would be best if they went and, was able to get some outside help. So, would be the process for me to, as someone, not the actual person going in, but to help a friend get in, and, how long would they have to stay? Because it is voluntary. Or,
if they're coming,
if it's involuntary,
Sure. So I'm going to just clarify that. So if it's an involuntary, a 72-hour hold, weekends and holidays do not count. People get surprised by that sometimes. So weekends and holidays don't count. But just because you're placed on a 72-hour hold doesn't mean you'll stay that whole time. Again, it's very individualized and dependent upon the person, right? So we get people on 72-hour holds all the time that are evaluated, and sometimes we discharge them on day 2. We discharge them even on day 1 sometimes, right? If, sometimes people are just really reactive in that moment, right? And we get them, or there's some kind of crisis going on, and then they're kind of stabilized, right? And so again, it's very patient and person dependent, I guess, and centered, if I want to use that word. We can't legally hold people, past 72 hours without either a court order. That's really the only way we can keep people there after 72 hours, which is a whole nother process. So usually we're working with people side by side to kind of make that happen. And if you're there voluntarily, you can request to leave, and we have what's called a 12-hour notice form. And reason being is that because if you're not really safe yet, but you're asking to leave, it gives our doctor a chance to assess you, and then a hold can be placed if we feel like you're going to be a danger to yourself or others if you're asking to go, if that makes sense.
I think that's a tricky aspect. So part of my career, I was a prosecutor for a long time, and I did adult protection to some degree. And I think that's a tricky aspect, that 72-hour hold and that voluntary versus involuntary, having friends who are suicidal and then they get discharged. We think that they get discharged maybe too early, and maybe, and so I think it causes a lot of miscommunication in terms of what the hospital can do and what we expect the hospital to do in those situations. So I think it's good to have that clarification that it's not necessarily a hold. Just because I take my friend to the ER because they're suicidal, they don't necessarily get put on a 72-hour hold at that point.
Correct.
They can be voluntarily admitted to the hospital and then they're on that. They can leave within 12 hours kind of thing.
Yeah, they have to make that request. And then again, at that point, we are assessing them. And if, they're not safe to go or we're not in agreement with that for whatever reason, then the physician can initiate that 72-hour hold to keep them there so we can assess longer.
Sure. Law enforcement can also put people on a 72-hour hold. So if
they can put them on a transport hold
and
cannot
then
put them
can,
on a 72-hour hold.
Sure.
Yeah.
That makes sense. And they can take them to you and then ask for the 72-hour hold.
Yes.
And it has to be a physician agreeing to that.
For the 72-hour hold? Yeah. Physician assistance or an actual medical doctor.
Okay.
Yeah.
Okay.
Yep.
Okay, so I kind of want to switch gears a little bit in the sense of okay, so obviously you will go in for the, for therapy, but what are kind of maybe some things you could do when you're outside the office to maybe help people cope or continue it even when they're not visiting?
In the unit or if they come to my office, tools that I'm giving them to cope outside of the office?
Yeah, tools that they can use outside.
Can we actually do both of those things? Because I think there's a question about what should people expect in the unit? Okay. And then a question about are there things that can be done outside? Is that fair?
Yeah, both questions. That's
Sure. So let's start with what to expect on the inpatient unit, because I actually think that might answer both questions.
Okay.
So what to expect on the inpatient unit. Once you get to us, you go through an admission process with our nurses and our behavioral health techs where we kind of gather a lot of history and that kind of thing, right? You can expect to see the psychiatrist on a daily basis. You can expect to see me on a regular basis. I do both group and individual therapy on the unit. Our behavioral health technicians all have 4-year degrees. Some of them have social work degrees. Some of them have psychology degrees.
Justice degrees.
Yeah. And we've had education teachers that have worked on our unit actually too. And so they do a lot of our group programming, and we really are a cognitive behavioral therapy kind of focused kind of programming because it's evidence-based. We know that it works, all of those types of things. So, and so you can expect all of that. We have a pretty, we do groups every day, all week long. We're pretty heavy in the group programming on the morning side, or more in the mornings, I would say. So you can expect to interact with all of those providers while you're there. And then while doing that, right, to answer the next question, our goal is to be giving you tools. As a matter of fact, most often I describe to patients, we see ourselves as a bridge, back out into the community. Our goal is to give you some tools to put in your tool belt so you can use them when you go back out. So all sorts of coping things. I mean, part of that is the cognitive behavioral therapy stuff, learning how to kind of challenge some of those unhelpful thoughts. Just because I think it doesn't mean it's true. We teach breathing stuff, relaxation, mindfulness, stress management kinds of things. How do you set boundaries with people? How do you assert yourself? We run kind of that whole gamut.
I think some of the misunderstood or less understood aspects, and I'd like to focus on suicide for just a second. Okay. When I was in school growing up, it was very much the idea that you shouldn't, if you ask somebody about suicide, that it would make them want to kill themselves. And so can you tell us a little bit about what the teaching is now?
Yeah, the teaching is not that now, right? We know that asking the question doesn't make people suicidal. I mean, if people are suicidal, they're thinking about it. And in fact, often asking them that question is often a relief because they don't necessarily want to disclose it. But if I offer it up, people are kind of relieved by that and are definitely more willing to share that. And that is actually part of when we think about Avera, we actually did a huge ask the question campaign as part of our suicide initiative program that we've done. And so, yeah, we've done kind of a lot of education around that, but yeah, we need to just be asking the question, right?
Yeah. So can you give us the 2 questions that you would recommend that we ask?
Well, are you experiencing or thinking about suicidal thoughts, right? And I would say, do you have a plan or have you started to form a plan?
Sure.
Have you been thinking about that?
Sure. And if somebody says yes to those questions, what do I do?
Mm-hmm. Good question. Mm-hmm. I mean, I think I would, at that point, I mean, if someone's actively suicidal, right? Because here's the other thing. I mean, there's a difference between someone who is actively suicidal and passively suicidal, right?
What do you mean by that?
Yeah. So I work with people every day in my clinic that experience passive suicidal ideation. They have no plan, they have no intent, and they have no means, right? Or they're denying those things at least. And so they kind of chronically have these thoughts that come and go, right? Like, maybe I'd be better off if I just wasn't here. I'd be okay if I didn't wake up tomorrow morning, you know, but they don't necessarily have like a plan or a desire to actually end their lives, right? So I also would ask, I mean, I maybe should back up. If someone says, yeah, I'm like suicidal, or they're talking to you about that, I would ask about intent, like plan, intent, means, right? Because those are going to be your three key things too. And if they really are thinking about a plan, they've started to formulate a plan, like maybe practice a plan, like those folks probably need to get to an emergency department to be evaluated.
So pretend they do want to call in, like, but they want to do it like anonymously. Like, is that something, or like how would that work? Or is that something that even would work?
Like calling in where? What do you mean? Like calling in?
They call into
the unit?
Yeah, but like maybe they call in, they tell, but they don't want to come in.
That happens to us, actually. Sometimes, so depending upon the situation and what they're sharing with us, like sometimes we try to capture their phone number, or we get them to tell us where they're at, and then we will actually, someone else will get on another phone and call for a welfare check.
To law enforcement.
To law enforcement to go out and try to do a welfare check or to find them, or if we can capture their phone number, because phone numbers will pop up on our phones, right? Like on our unit, we can give them that and see if they can run it for us. So we do that, and we have done that.
Sure.
We've called welfare checks for people who have called in to, you know, just talk sometimes in the middle of the night. And if we're like have really concerns about them, we try to figure it out.
So is there a resource that somebody can call, like the 988 line?
Yeah.
What is that all about?
Yeah, 988 is just the national suicide hotline number, right? Where you can call or text it, and someone's available 24/7. So I feel like they did a good service when they made that much shorter than the like regular phone number. So you have 988, right? And then you have, you know, Western Mental Health Center's local crisis phone number too, which I'm sure that they provided
about,
during their time with you as well. So I mean, they would be a nice local resource too. So.
So, like, what would you kind of say, like, anyone who watches this, like, what's the biggest thing they should just take away from this? Like, something that, like, all right, I'm finished watching it. What would you say, like, the biggest key?
Good question. I mean, I think a big takeaway probably for students is to ask the question. I think we get scared to ask the question because we're afraid of maybe the answer, you know, but hopefully with all the resources that students are being given through this entire kind of podcast, right? Like you kind of know what to do with that then when you get it. Or, you know, you get that positive answer maybe, right? Like, yeah, I am suicidal. So I think asking the question, and I just hope that in all of this, that people aren't afraid to seek services and to get the help they need.
It's that whole One Flew Over Cuckoo's Nest, Nurse Ratched situation. Freaks people out.
Right. I mean, and I would say, you know, in terms of our unit, it can be scary. And it's interesting the amount of people that we get and they're like, wow, this wasn't what I was expecting.
Right.
I mean, our behavioral health unit's pretty homey. It's, you know, it's 10 beds. We're pretty quiet. Everybody, you know, all patients have their own bedroom. They have their own bathroom. We eat, you know, they eat together in the dining area. There's one TV. We do not have TVs in all the patients' rooms. They do not get access to cell phones, but we have a phone and it calls long distance. So we've had people actually call other countries, like across the United States, whatever. And so, you know, and we just really try to work with people, like. You know,
and you have visiting hours as well.
Yeah, we do. We have visiting hours. Yeah, yep. Regular visiting hours, Monday through Friday from 6 to 8 p.m. And on Saturday and Sunday and holidays, it's 1:30 p.m. to 8 p.m. And we also make, you know, what's the word that I'm looking for? And we make
Special
exceptions to that.
accommodations.
Yeah, to that. Especially, we admit people to our unit from all over the state. So sometimes we have people driving 3 hours to come and visit their loved one. And so it's like, yeah, you can come during the day. We don't want you driving home at 8 o'clock at night to get back home again.